Well, good afternoon, everybody, and welcome to this Parkinson's Academy webinar. A huge thank you to our sponsors, Kayo Kirin, without whom we would not be able to run what promises to be a very topical discussion. Tracy Smith and Norman Cock discussing the management of postural hypertension in Parkinson's. So, without any further ado, let me hand over to Norman to start this afternoon session. Norman, over to you.
Thank you. Welcome everyone. So my name is Norman Cock, and I work at the East and North Herts NHS Trust as a consultant neurologist. And today with me is Tracy Smith, Parkinson's nurse. And thank you first of all to Kayo Kirin for sponsoring this session, and I really enjoyed preparing the talk for today. It's always a good reminder. So you can see here postural orthostatic hypertension, and that's synonymous. So lots of people get confused, and but for the remainder of the talk, I will refer to it as orthostatic hypertension. And as you can see here, it has something to do with our planet. So this is the overview. So I'll give a short definition and talk a bit about epidemiology, then about how to make this diagnosis, etiology, and also gravity about our planet. Then what we can do about treatment, short word on the opposite, which is supine hypertension, and then a brief summary. Right, and of course Tracy will join me when we talk about treatment, as this is obviously very to the heart of all of us. So definition, so orthostatic hypertension is a fall in systolic blood pressure of at least 20 millimeter mercury, and or a fall in diastolic blood pressure of at least 10 millimeter mercury. And the next bit is important, within 3 minutes of standing. So in order to really measure it, you have to wait 3 minutes. And the other important bit is that I'll tell you now that it's very important to measure heart rate at the same time, as you can actually identify with heart rate changes whether or not it's a neurogenic cause. But I will talk to you about this in further in the session. So the key thing about everything is if this actually causes symptoms. So if you forget everything about this talk today, the one thing I want you to remember is it's about symptoms and not the reading. So if patients do not have symptoms, we do not tend to treat them. Because having orthostatic hypertension is very common, and I will talk to you about that a bit later as well. And the symptoms are varied and sometimes missed. The most common that we all are aware of is that people can pass out, they can faint, or technical term would be syncope. But more common is actually that they have pre-syncope, some symptoms of blurred vision or darkened vision, or just simply feeling lightheaded. It may affect muscle perfusion as well, particularly the big muscles around the spine, causing coat hanger pain or lower back pain. It can even cause symptoms of angina. And sometimes, surprisingly, you investigate these patients and they don't have any coronary artery stenosis. They may get fatigue and dyspnea, difficulty breathing, and even reduced urinary output. The key thing about all of this is that this only occurs while they're standing and disappears quickly when they lie down. So I would be very careful to attribute angina to orthostatic hypertension if it happens while patients are seated and lying down. So how common is this problem? It's very common. And actually, up and down the country, we encourage everyone to measure blood pressure, lying and standing in everyone aged 65 and older when they're admitted to hospital. And that's due to a simple fact of aging. Our baroreceptors become just not as sensitive anymore. But not all of that is symptomatic. Now, obviously, most of us here are very interested in Parkinson's. So in Parkinson's disease, this is very common. About half of patients have it. More common, obviously, in patients with autonomic dysfunction and multisystem atrophy. And it's the definition that you have to have the symptoms for pure autonomic failure. But also, interestingly, you can get it with other neurological conditions, such as spinal cord injury, particularly in patients who've had paraplegia, but also in diabetes, of course. So, and I'm sure you all have patients who have both Parkinson's and diabetes, and that is often a very big problem, getting postural hypotension, but it can just happen in patients who have diabetes and increases with duration and age. In Parkinson's disease, this is usually not something that should occur early. So if somebody gets these symptoms very early on, think again, they might have MSA. It's much more common when people are older, had Parkinson's for longer, are on higher doses of levodopa, and also if they have cognitive problems alongside it. So now, how to measure it? So I think this is done wrong so many times, and it's important to review this because, in clinic, everybody's rushed, you do it quickly. Sometimes it's just done sitting and standing. So the correct way to do this is to ask patients to lie down and rest on their back for 5 minutes, and then to measure and record both blood pressure and heart rate. And then you ask the patient to stand up and you wait 3 minutes. Now, a lot of people measure it right away, and there's nothing wrong with that, but the important measure is actually after 3 minutes. So if you're pressed for time and how long the blood pressure reading takes, I would suggest to do it after 3 minutes. And again, record both blood pressure and heart rate. But of course, patients may get symptomatic, they may get dizzy or may be about to fall, and then I would say stop and lie down. You don't want somebody to actually pass out or injure themselves. And you can then repeat it after a while, once they're recovered, just measuring lying and sitting blood pressure instead. In my experience, automatic blood pressure machines often give an error reading, particularly if the blood pressure drops a lot. Maybe it's just because I have an old machine, but I still like old-fashioned manual readings, and you may want to go back to this if you can't get a reading or it just doesn't seem to make any sense. So a common scenario that I get asked about is, oh, this patient passed out on standing. And then immediately my first question is, was this a faint, or was this due to orthostatic hypotension, or was it a simple faint? And what we call vasovagal syncope, because those are very common, particularly in younger people. So if somebody has a history of fainting all their life, it's, so that might still be the case. It may not be neurogenic orthostatic hypotension. Interestingly, faints are more common in females than in males, and it tends to be the opposite when with neurogenic orthostatic hypertension. The symptoms for syncope are often after prolonged sitting or standing, versus neurogenic can occur much faster. But you can have patients also with neurogenic orthostatic hypertension who only present with symptoms later. So none of this is absolute, it's just as a hint. And as I mentioned, pre-syncope is much more common in orthostatic hypotension compared to vasovagal syncope. And if you measure the blood pressure, it's still abnormal, versus in syncope, it normalizes very quickly once patients are supine again. And the second question, obviously, if you decided this is orthostatic hypotension, is this neurogenic or non-neurogenic? Because not every drop in blood pressure is due to autonomic system failure. Now, the gold standard test that is not really used that wildly is plasma neuroepinephrine response. And, in patients who have a normal response, this should increase once they stand up, and you may not see a reduced level or no increase in patients with neurogenic orthostatic hypotension. The other way to measure it is to do a Valsalva maneuver. That's usually done by cardiologists when they do tilt table testing. And what you usually get is an overshoot in the fourth phase of Valsalva, and that's absent in orthostatic hypotension, neurogenic orthostatic hypertension. But this is complicated, and you may get some patients that are seeing a cardiologist with tilt table testing and going to a lab, and when it's unclear, this is very useful, but much more useful is to actually do bedside tests, and it's quite simple actually. So all you need to do is take the change in heart rate, or delta HR, between your lying and standing readings, divided by the change in systolic blood pressure, or delta SBP. And usually, if you see in non-neurogenic orthostatic hypertension and overshoot, you see that the heart rate compensatorily increases a lot. And basically in neurogenic orthostatic hypertension, this doesn't. And a lot of times you don't actually have to calculate, it's pretty obvious. And here you can see two diagrams illustrating this. So on the left, you can see a patient with non-neurogenic orthostatic hypertension. The black bars represent both systolic and diastolic blood pressure, and in red, you can see the heart rate. So lying supine, nothing much changes. Then patient is asked to stand up. Blood pressure drops, both systolic and diastolic, significantly, but heart rate goes up a lot. And then when they lie down again, things normalize. Whereas on the right-hand side, you see this patient with neurogenic orthostatic hypertension, where basically the heart rate doesn't change at all between lying and standing, and lying down again, whereas is the blood pressure dropping significantly. So the absence in heart rate, and this is often not reported. Usually patients get referred to me by the GP, or even in outpatients, the blood pressure gets recorded, but not the heart rate. And it's so critical and so easy to do because you would treat it very differently if it's non-neurogenic versus neurogenic. But I get to that in a minute. So now going back to etiology, why do people have that? And we talked about neurogenic orthostatic hypertension, particularly in Parkinson's disease, MSA, and other neurological conditions, as well as diabetes. But as I said, it is just orthostatic hypertension is common phenomenon in aging, even in the absence of any other neurological disease. And the most common thing is people don't drink enough water. And I usually tell my patients, you have to put enough water in the system to maintain pressure, giving the example of having enough air in a tire. And they immediately understand that. There are certain medications that can precipitate this problem, and I'm a bit interested in astronomy and space flights. So I was very interested in this. To make it a bit more lighthearted. So 20% of people going to space get orthostatic hypertension when they come back to Earth, and 83% of space travelers after long-term flights. So let's talk about that a bit. So gravity is obviously not unique to Earth, but we have a distinct set of gravity, and we've evolved to live with this. And this is part of the problem when it fails. Now in space, what happens is that astronauts, because there is no gravity, the blood pools into the upper body. And if you look at astronauts next time you see them on television, they have a puffy face, and their upper body is quite enlarged, whereas they have very thin legs, chicken legs. And obviously when they return to Earth and are exposed to gravity, it's the opposite, and they can be symptomatic. So, ask your patients if they've been to space lately. Right, so aging, what does aging do? So we have baroreceptors in the carotid artery and around the aorta. And they measure, it's a mechanical receptor, they measure basically the extension. And if there's a drop, it immediately gives a feedback loop to increase blood pressure. And that loop doesn't work that well as we age. And as I said, reduced volume in the system is a big problem. And what happens if you ask patients to lie in bed for about 3 days, a lot of the water in the system goes into the third space and is not available anymore, and therefore they get postural hypotension, orthostatic hypotension. And if you ask somebody to lie in bed for a very long time, then also the skeletal pump function decreases, and that's on average about 2 weeks of bed rest. So, and if we think of our long stay patients, so that explains some of the issues. And obviously, some medications we give patients to control blood pressure also cause problems. Now, the neurogenic causes I mentioned here, Parkinson's, Lewy body, multisystem atrophy, but also stroke can cause it, and amyloidosis and diabetes. So now talking about treatment, and so basically when I get asked about it, it's always like, okay, which medication would you use? And you always have to step back and say like, no, we have to review the patient as a whole. And I would call this, well, I haven't called this, I mean, it has been called a 4-step approach. So basically the first step is to review and adjust any medications that may precipitate or cause symptoms, and then use non-pharmacological measures before you use any other treatment. And then as a 4th step, you might combine all of these in order to help. Again, to emphasize, you should not treat just the blood pressure drop if patients have no symptoms. We can't cure the problem. So there will always be a blood pressure drop. It's just whether or not patients have symptoms or not. So if you detect it, I warn patients that, well, they might become symptomatic, to tell them about the symptoms they may experience later on. So the first step, as I said, so please review medications and conditions which could worsen the symptom. So if somebody's anemic, hypoglycemic, hypothyroid, and has heart disease, it's not surprising that they may get postural hypotension. And I rely on my cardiologist to help out with that and identifying the medications that can be safely reduced or stopped, because some of them may be very important for their cardiac condition. In my experience, it's particularly diuretics and alpha blockers that seem to create lots of the problems, and we try and reduce those first. But just look on the other side, there's lots of other medications that can worsen symptoms as well. Just to mention alcohol, lots of our patients like to drink 1 glass of wine or something like that, which could a night, which could certainly worsen symptoms. And then I'll hand over to Tracy for the non-pharmacological measures.
Thank you, Norman, for that comprehensive introduction to orthostatic hypotension, and thank you to our sponsors, Kyowa Kirin, for enabling us to participate in this webinar. So I suppose, you're looking at a list here of different approaches to non-pharmacological treatment options and advice that we give regularly to patients and healthcare professionals. I suppose the only thing, gambit I'd bring on here is that if we're going to use support stockings, these should be measured and prescribed to ensure that they actually have an appropriate effect. As with all healthcare professionals, all healthcare issues, treatments and decisions are key in patient experience and patient safety. Patient education is available in many formats. There's access through Parkinson's UK online, also through their local support groups, as well as NHS UK websites. Education, though, should start at the point of diagnosis. It is really essential that we empower patients to really manage themselves. In our area, I developed an anticipatory care plan. This basically identifies some of the reasons that people deteriorate with their Parkinson's and with concomitant infections. And this is also a useful tool for community services. The information in this includes patients being aware what changes of medications can do. Is it a different medication, a change in dose, and what the negative symptoms could be? There's a lot of information in there on orthostatic hypotension. how to avoid it and how to recognise it. The same with chest infections and constipation. Also, there's a section on dehydration and delirium secondary to infection. And all of these issues are really key in keeping patients well in the community. This booklet was actually developed, or the idea of this was developed by retired Parkinson's nurse specialist Pete Smith, who many of you will know. This was approved by Parkinson's UK. Obviously, patient education should be ongoing and personalised to their individual symptoms and lifestyle in the hope of promoting autonomy and patient well-being. And as Norman alluded to, understanding hydration is key. My mantra is hydration, hydration, hydration. Generally, the population does not drink enough water. And people need to understand what water does to their body and the fact that we are approximately 60% of O2. So I have a list of areas where good hydration is helpful. It manufactures hormones and neurotransmitters, which are key in Parkinson's disease. It regulates body temperature, sweating, respiration, and saliva. It acts as a shock absorber for our brain and our spinal cord. It converts food to components needed for survival and digestion. It helps to deliver oxygen all through the bodily systems. It is a major component in most bodily parts. It lubricates the joints and it flushes bodily waste, mainly in the urine, thus reducing the risk of urinary infections. It allows body cells to grow, reproduce and survive, and keeps musculoskeletal membranes moist. So there's a lot going on in the need for better hydration. If we look at constipation, this is defined as only passing stools at 3 times a week and being effortful and hard to pass. Constipation is caused by not taking in enough fibre and fluids, and also contributed to by reduced motor activity. It's also a side effect of multiple medications. I'm sure most of you use this saying, if you don't use it, you lose it. There's a lot of evidence to say that dopamine is produced by physical activity. There are lots of different online components out there, and a lot of local services have adapted their therapy delivery to provide evidence-based physiotherapy and motor activity in improving their well-being and function. So if everybody does all of this and you will manage to avoid hospitalisation, fabulous. However, some people don't manage to avoid hospitalisation, and this is when things get more challenging. So why on earth do things go wrong? If patients are unwell enough to be admitted to hospital, it's likely they have already missed doses at home, hence arriving in hospital in an off state. They are often unable to swallow or are confused and assessed as at risk of falls and then kept in bed. As we know, if you do not use it, you lose it. So any prolonged periods in bed are not good for anybody, but worse for people with Parkinson's. We did carry out an audit on the use of the rotigotine patch, which is used when patients are acutely unwell and deemed nil by mouth by a swallow assessment, which is the initial assessment that's done when they come into hospital. We looked at how long patients were kept on the patch and how long it was before they had another swallow assessment. The results of this audit actually prompted us to change our guidelines, and we now promote use of NG tubes as an initial treatment for people who come in and are deemed nil by mouth, but this must be reviewed within 12 to 24 hours. This has reduced the use of the patch and the length of time that people are on them. It has to be said that a lot of these patients, when admitted, unfortunately, are quite complex in their stage of disease, and the majority of the patients that were part of our audit had actually come from care homes. So when we look at nutrition and hydration, there is much documented, particularly with the Royal College of Nursing, and it identified 10 key areas required for appropriate nutrition and hydration for patients' health and well-being. As I say, we do a lot of education and trying to get patients to manage this well at home, but there are obvious factors that exist in hospitals that can compromise this. And there were 10 initially identified key areas that were recommended for all hospitals and any institution to have. So this could be care homes. So initially you must screen and identify potential malnutrition. You must develop specific care plans for and with that patient in relation to hydration and nutrition, ensure that there are local guidances in place and that service users were involved in the development of these guidance. Protected meal times became quite a big issue before COVID, and staff and volunteers and relatives were encouraged to participate in these protected mealtime provisions. However, since COVID, this has not yet returned. Staff training in understanding the importance of nutrition and hydration and how quickly things can go wrong. There needs to be 24-hour food made available and policies to ensure that safe nutrition and hydration should also be available. Safe delivery of food and drinks is also key, and a multidisciplinary approach is required. So the problem with patients is they come in and they're often in an off state, so they do not drink enough, they often don't have enough nutrition, they may be left nil by mouth for too long and not assessed by the speech and language therapist. This then increases the risk of postural hypotension. So if we look at delirium secondary to infection, this is a huge contributory factor to patients' well-being in the community, living alone, in care settings and in an acute setting. It is really important that we identify whether this is cognitive impairment and progressive neuropsychiatric issues in relation to their disease progression, or whether it is really delirium secondary to infection. And I know in the acute trust, sometimes they're diagnosed with delirium secondary to infection, but actually there are no infection markers to be found. So it's really important we know our patients. Patients often come into hospital with advanced dementia and coming from care homes, and there's a real need to ensure that documentation and preferred places of care are achieved in the community, and that family and the multidisciplinary team are aware, particularly if they have power of attorney, of what the preferred places of care would be. Some of these patients have very prolonged stays in hospital, and it's really important that if we can keep them out, that we do. So in 2018, 9 trusts in the east of England were part of a pilot titled PJ Paralysis. This was a campaign to improve patient activity in hospitals and reduce the amount of time patients spend in bed. The results were very significant, and during that pilot with those 9 trusts, it was deemed that 250 years were saved, or 91,728 days worth of time. As a result, the Chief Nursing Officer built this as a national rolling programme. In 2021, they had a summit, and this continues to be promoted to improve patient experience and outcomes. But why? So the prolonged periods in bed, you have muscle wastage. Your aerobic even capacity and physical power deteriorate. When these issues happen, there is accelerated bone loss and increased risk of disability. There's an increased risk of needing institutionalized care, and can directly lead to pressure ulcer development, falls, malnutrition, sensory deprivation, and incontinence. All of this clearly impacts on patient quality of life and patient outcomes. We have frailty teams now, both in the community and in acute trusts, and these are key for our patients with comorbidities, advanced disease, in ensuring that we try and keep them out of hospital. They provide hot clinics to promote hospital admission avoidance, but if patients do come into hospital, they support timely discharge and outpatient follow-up, or if appropriate, community follow-up. We have safeguarding teams. These are generally excellent in supporting our patients. They have extra qualifications in understanding delirium and dementia and neuropsychiatric complications. There is good evidence that the input of these services reduces falls, reduces length of stay, and supports timely discharge. Admiral nurses are also key, and again, these are community and acute based and can be really supportive for these patients living with dementia. It is absolutely absolutely essential that referrals for inpatients and concerns about patients in the community are made to their neurology consultant specialist and the nurse specialist, as well as therapy teams, in a hope to avoid admissions. So let's look at profiling beds. Profiling beds are defined by the Health and Safety Executive and the 1992 Manual Handling Operations Regulation as a main benefit of staff safety, as well as a benefit in cost saving of less nursing time. The Royal College of Nursing look at this, and they identified that 52% of manual handling accidents involved patients' beds, typically while moving patients up and or down bed and helping them sit up or turn in bed. An electric profiling bed is that it has a sectioned mattress that can be profiled to achieve various positions. The height can also be adjusted, and movement is powered by a control by the bedside. It can be used by staff or, if appropriate, for the patient, and can facilitate the patient being independent in their bed area. There are huge health benefits to using profiling beds appropriately. Improve lung function, reduce cardiac workload and improves cardiac output, improves urinary drainage and reduces infection risk, improves gut mobility and nutrient absorption, and reduces muscle wastage while maintaining joint flexibility. However, for me, using a profiling bed is key in reducing the development of postural hypotension or deteriorating already existing postural hypotension. It is essential we have the right equipment, either in the community or the hospital, that is the right thing for the right patient. These two slides demonstrate the usual two positions that I see as an acute Parkinson's nurse specialist, and as I used to see in the community when patients had this equipment at home. This slide shows 12 adjustable positions that can help, and for me, I really want patients to be in the bed at the risk of falls when they're unwell, confused and delirious. Orthostatic hypertension will get worse. It is essential that we use all of the positions to ensure that these patients do not deteriorate and that we improve their outcome and discharge planning. As in the words of Star Trek travel, resistance is futile. I will keep being a champion for patients and staff using the full range of profiling beds. Over to you, Norman.
Thanks, Tracy. That was excellent. Yeah, so key is really to use everything at your disposal to improve things with non-pharmacological measures. Going back to the astronauts, that's exactly what they do with them as well. So they drink salt water basically in order to increase their plasma volume. There were compression garments, you know, akin to compression stockings or binders that we use on Earth. And as the last measure, you know, they are giving Midade. Anyway, one day I'll go to space, who knows? So what everybody asks me about is medications. And in the UK, it mainly comes down to Midade and Photocortisone, but there are others, and I will touch upon that briefly. So Midade is actually licensed to treat a neurogenic orthostatic hypertension in the UK. There's nice guidance here for anyone who's interested. It's an interesting read. The way it works is it's an alpha-1 adrenergic receptor agonist. And what's interesting is that it's selective to vascular smooth muscle, not 100% selective, but quite selective. And that's why it's so useful in orthostatic hypertension. Now, I usually start with a very low dose, 2.5 milligram, 3 times daily, and then increase. And the key thing is that you shouldn't give it before patients are lying down. So, if you know patients go to bed early, around 8 p.m., then, you have to calculate when are you giving the last dose, because otherwise you will cause supine hypertension. And then I usually titrate very slowly, not faster than every 3 to 4 days, increasing the dose just to check if there is any improvement. Important to note is that patients also can get skin itching, so you can warn them about that, and urinary retention. It should really be only used very carefully in heart failure or chronic kidney disease. And again, I, as a neurologist, rely on my elderly care physicians mainly to help me out, to make sure that I'm not causing other problems. Photocortisone used to be the standard treatment that we give to patients, but actually it's an off-label substance. But there is nice guidance, as you can see here, from October 2013. So we are allowed to use it, we can use it, and it is very potent. It's a very potent mineralocorticoid, and the way it works is it expands the intravascular blood volume. I usually use, again, a very low dose, 100 microgram, and don't tend to go higher than 200 unless I absolutely have to. I don't find higher doses are actually that helpful. Again, it can cause supine hypertension, and because of the mineralocorticoid affect also hypokalemia and edema, and therefore should be avoided in congestive heart failure. Patients need potassium supplements most of the time. Measure it. You can create otherwise other problems. And nice guidance suggests that we should give them steroid cards, particularly if they're on this medication long term. That's usually given by pharmacists. So, I was like, oh, where can I find the card? So pharmacists are usually very helpful and will give them out. So other drugs, so one drug that I found useful in addition to midodrine or photocortisone is periodistigmine. Most neurologists know that as a drug for myasthenia gravis, but it can be quite helpful to be given in addition. The way it works is it increases sympathetic activity, particularly in response to orthostasis. So again, I use a very low dose, 30 milligram, 3 times daily, and you can titrate it up as you would in myasthenia. But unfortunately, it can cause lots of GI problems, pain, diarrhea, sialorrhea, and also sweating, and which is interesting. A lot of my patients with orthostatic hypotension and autonomic failure have difficulty sweating, so it can actually be useful to add this in sometimes. Droxidopa is a drug that you may have come across because in a lot of talks and publications it is used. It's particularly used in the US and in Japan, but not licensed currently in the UK. What's interesting about it is it's a prodrug to norepinephrine and seems to have less risk of supine hypertension compared to fluorocortisone and midodrine, but I have not had any experience myself. Which gives me, it goes nicely to the last part, supine hypertension, something we all worry about. So we now have a consensus statement that we should basically rate the hypertension based on its severity. You can see the numbers here. It's defined as systolic blood pressure of more than 140 or more diastolic more than 90 after 5 minutes of rest, which I guess, if you're measuring orthostatic hypertension, how I suggested, you will pick up anyway. How to treat this? So the main thing is to avoid antihypertensives during the day when patients are upright, because remember, that's when they have the postural hypotension. So don't give them antihypertensives during the day, and warn patients that they should not lie down during the day. Avoid naps. They could nap in a semi-recumbent way on a chair if necessary. And you can use postprandial hypotension at night to help, because we know that after eating, blood pressure drops in these patients. So having a meal or snack at night, or even a tiny bit of alcohol at night, can actually be helpful to reduce supine hypertension. If really necessary, then short-acting antihypertensives can be used. I've mentioned a few here. I particularly like using the nitroglycerin patch, because you can put it on and take it off quite easily. But there are others that you can use. Now, the good news is, and I've been backed up by my friend cardiologist on this and seeing patients over the years, is that supine hypertension is not as much of a problem as we think. Everybody gets panicked about it, but actually the problem, and that's what we need to treat, is postural hypotension, because that leads to falls and admissions. And the supine hypertension, unless it's severe, does not seem to cause any problems to the heart or increase in heart attacks. So there's a lot of reassurance that I have to give to GPs and patients alike. Right, so in summary, orthostatic hypertension is a common problem in the elderly, not just in Parkinson's disease. You need to think about it to detect it, but then don't panic, treat the symptoms, not just the blood pressure. The drop cannot be cured. There will always be a drop. Use a four-step approach in treatment. Don't rush to putting everybody on Photocortisone, but talk to patients about all of the implications of low blood pressure and high blood pressure, so that they're not scared if their supine blood pressure is a bit higher than they normally would like. There's a lot to be said about patient education and self-management, as Tracy pointed out so well. And lastly, I want to say that gravity is both your friend and your enemy. And with that, I will stop.
Well, thank you, Norman and Tracy, for an incredibly comprehensive review of orthostatic hypertension and how to treat it. And Tracy, you have a fan base out there. We've had a couple of huge thank yous. That was one of the most comprehensive nursing treatments that they've ever heard, and that will really help in supporting their hospital and ward colleagues in understanding what to do. So that's why we do this. So thank you very much. So we have some questions. So let me go to one of the first ones that came in, which was from Nirav. So if somebody has symptomatic orthostatic hypertension, should that preclude them from starting on levodopa therapy until the OH is sorted out? Norman, what do you think?
Yeah, that's an excellent question. I mean, you know, again, I would use the four-step approach just to check. It might be very easy actually to reduce the symptoms by asking them to drink more water. Particularly patients who've just been diagnosed with Parkinson's often are very dehydrated. They're so slow, they may forget to drink. And actually giving them levodopa, giving them more activity, along with advice to drink more water, often the combination is enough. So I don't necessarily find that it would preclude me, but as I said, I'm mainly worried if it's not easy to treat and it's neurogenic orthostatic hypotension rather than non-neurogenic and lack of water, maybe we're not looking at Parkinson's, maybe we're actually looking here at somebody with multisystem atrophy, and you know, so then screen for other autonomic dysfunctions. But again, with multisystem atrophy, even then we try patients on dopamine because we want them, and a lot of them have some benefit initially, maybe not for very long, maybe just for a couple of years. But I still think it's worth doing. Again, it's about patient education, making sure that they understand what all of these drugs do, what they can do, what they can't do, how they can help. So again, it's not a yes or no, but it's an individual kind of approach, like all of these patients, and they teach me so much. Every single patient that I see, even after all these years, I think I've seen it all, but I haven't.
Excellent, thank you very much. So Alison Leek asks, is there a link between postural hypertension and high urine output overnight, as she has 2 advanced patients with both issues? And I can see Norman and Tracy nodding. Norman.
Yes, I mean, I think what we try to do to mitigate that, because it is so common, is to ask patients to raise their head by 15 degrees or 30 centimeters, you know, the bed rest, because that will reduce that. So it's a very common problem, and it makes things worse, really. But yeah, I mean, it's again, you have to look at it holistically, see how much water they drink, see if they drink anything that also adds to the problem, like caffeine. You know, a lot of patients like to drink their tea. So yeah, I mean, that's what I do.
There's lots of questions coming in. I've got time for one more. So Glyn Scott has asked, if using a nitroglycerin patch for supine hypertension, is it simply a case of putting it on at bedtime and removing it on getting up?
Yes.
Yep. It's as simple as that, Glyn. Marvellous. Brilliant. Thank you very much.